Hello, everybody, and welcome to the sixth and final talk to the Parkinson's Foundation's 8th expert briefing series for Parkinson's disease. And our topic today is sleep and Parkinson's, and this is going to be a really fantastic session. We have 1,100 people registered, almost 1,200 actually, from 21 different countries and all 50 states. So this is going to be fantastic. I'm Dr. Jim Beck, Chief Scientific Officer at the Parkinson's Foundation. This expert briefing is something that we have done in collaboration with our members of our community, particularly the Alliance of Independent Regional Parkinson's Organizations, AIRPO. Thank you for your support. Also want to thank our sponsors, without whom this series would not be possible. They include AbbVie, Acadia Pharmaceuticals, Lundbeck, and again, without their support, this would not be possible. For those of you who want the PowerPoint slide that's going to be presented today by our speaker, it can be downloaded. If you look in the lower left-hand section of your viewing page, you can see a download slides link, and you can download a PDF file any time during the talk today. If you're a health professional, you can earn one free CEU through the American Society on Aging. If you're registered as a health professional and indicated you'd like CEUs, you will receive an email by the end of the talk today with steps on how to collect your one free CEU. You have just 30 days, so that's until July 13th to collect your free CEU. It's my pleasure to welcome our guest speaker, Dr. Aleksandar Videnovic. He's Associate Professor of Neurology, Director of the Mass General Program on Sleep, Circadian Biology, and Neurodegeneration at the Massachusetts General Hospital and Harvard Medical School. Dr. Vidonovic's clinical activities include diagnosing and treating Parkinson's disease and sleep issues related to Parkinson's disease. His research really focuses on the relationship between sleep, circadian biology, and Parkinson's. In 2007, he was the first recipient of a 3-year fellowship, Clinician Scientist Research Award, sponsored by the Parkinson's Foundation and the American Brain Foundation to study circadian rhythms and Parkinson's disease, really beginning to stake a name for himself in this area and open this area up to research. Dr. Videnovic received his medical degree from the University of Belgrade School of Medicine. He completed his neurology residency at Northwestern University, Feinberg School of Medicine in Chicago, and he did MUMSORTER fellowship training at Rush University and at Northwestern University. Dr. Videnovic also holds a master in clinical research, which has served him well. He's going to talk a lot about his research today. So at this point, I'd like to also make a quick shout out to our Ohio chapter. Welcome. I understand we have a viewing party there, so that is something that's going to be really great, and I hope everyone enjoys our talk today. So Dr. Videnovic, let me turn it over to you.
Thank you very much, Dr. Beck. Hello, everyone. I would like to thank everybody for joining us today for this webinar series, and would also like to thank Parkinson's Disease Foundation for recognizing the need to put this topic up for this webinar presentation and discussion to follow. And I'm certainly appreciative of this opportunity to share some of my thoughts on problems that happen with sleep and alertness in Parkinson's disease, which are very common non-motor manifestations of this disorder. We all know that Parkinson's is on the rise, and this chart of the globe here is to illustrate that the number of individuals affected by Parkinson's disease will double, even triple, in the most populous nations on the planet. Therefore, this is becoming a very important public health issue, and developing novel treatment strategies and empowering our patients and our public in regard to the knowledge about this disease will be very relevant in years and decades to come. It's relevant today as well, but we'll deal with more and more patients that will need to get good care. And therefore, I think, that this webinar series that brings us actually world together, considering how many countries are participating on the call today, is just really a wonderful mission that Parkinson's Disease Foundation has put forward. I am going to speak to you today about problems with sleep and alertness that occur in Parkinson's disease, and this is a very complex topic. And this slide, more precisely this scheme here that I put together really illustrates how complex is the study of sleep and alertness in Parkinson's disease. And why is that? Well, it is because our patients with Parkinson's disease are very different. If you have Parkinson's disease, are very different from your neighbor and a relative that may have same disease. Yet you both may experience problems with sleep and alertness. And yes, the cause can be Parkinson's disease itself and all that neuronal loss of nerve cells associated with Parkinson's disease, that cells that are important for the regulation of sleep-wake cycles. But you also see on the outskirts of this graph many other symptoms of Parkinson's disease, such as medication side effects, autonomic dysfunction, motor symptoms of the disease, neuropsychiatric symptoms, and other primary sleep disorders that also may contribute to poor sleep-wake cycles in Parkinson's disease. Therefore, the topic is very complex, the causes are very numerous, and therefore one needs to appreciate those complexities when reaching out to their physician, who needs to properly diagnose and eventually treat this problem either with sleep, nighttime sleep, or daytime alertness. And we will start by just talking a little bit about sleep and how is sleep organized, and some basic terminology is useful because it will help us as I move through this discussion further. Sleep is basically composed of two big stages of sleep, non-REM sleep and REM sleep. And REM sleep on this graph here is illustrated by these black blocks, and these other episodes, this other non-REM sleep is composed of several different substages here in blue, red, green, and yellow. And you can appreciate how these blocks of non-REM sleep and REM sleep cycle throughout the nighttime, and how we move from one stage of sleep to another stage of sleep. This is important because certain sleep disorders have predilection either for non-REM sleep or REM sleep. And now one needs to appreciate that Parkinson's disease is basically disease of aging, and aging is the biggest risk factor for developing Parkinson's disease. But even individuals who don't have Parkinson's disease but are older individuals notice some changes in their sleep pattern. Their sleep becomes less efficient. There are more nighttime arousals during the daytime. There is increased prevalence of sleep disorders as we age, and certainly a lot of us as we age feel increased burden of being sleepy during the daytime. So Parkinson's disease puts another layer on top of these challenges that occur with sleep throughout the process of normal aging. This year we celebrate 200 years since Jane Parkinson described what is later become to known Parkinson's disease in his honor. And in his famous essay on shaken palsy, published 2 centuries ago, he spoke about poor sleep. And here on the screen you can read one quotation that Jane Parkinson put forward that clearly illustrates his clinical acumen and how superb clinician he was, that even at that stage, in the very early stages, before the disease was even known, he was able to recognize sleep issues in his initial cohort of patients that he described, and that Charcot, French physician with many decades later, named into his honor as Parkinson's disease. So when we talk about sleep in Parkinson's disease, it's fair to say that almost every patient will experience some type of sleep problems throughout the lifelong course of their Parkinson's disease. And one need to really talk about nocturnal sleep problems, but also we cannot dismiss and forget about excessive daytime sleepiness, because that can have negative impact on daily lives, even more sometimes than relatively poor sleep quality at night. And now we start discussing these problems that occur with overnight sleep in Parkinson's disease. And these are some of the causes that illustrate what may be driving sleep problems in Parkinson's disease, and we will go over each of these problems during this talk. So let's start with the most commonly reported problem with sleep that our patients are telling us about. That is sleep fragmentation. Usually, patients with Parkinson's disease can go to bed when they are tired and they usually fall asleep nicely. But what happens thereafter is that they have repetitive awakenings during the nighttime, and during some or many of these awakenings, it can be quite challenging to fall back to sleep. This is by far the most common problem with nocturnal sleep in Parkinson's disease, and the causes are numerous. Tremor may persist in light stages of sleep, and as patients usually fall asleep into a deeper sleep, that tremor disappears. But any awakening overnight is associated with reemergence of tremor, or may be associated with reemergence of tremor. At that time, patients may realize that they are very stiff and it's very hard to move in bed. And therefore, these problems can cause a lot of trouble with falling back to sleep. Sometimes patients may have dystonic painful spasms like toe curlings or any involuntary muscle contractions that certainly pose challenges to sleep continuation. Sometimes patients have to get up to urinate, a phenomenon that is known to nocturia, and this can occur many times throughout the night, which poses challenges not only to sleep quality, but places our patients to risk at falls because they need to get out of bed. They are sleep deprived, they didn't get a good night of sleep, yet they need to go to the bathroom. So therefore, as a clinician, I pay a lot of attention to phenomena of nocturia, not only because it's a burdensome autonomic symptom or impairs sleep, but causes significant potential safety risks to our patients. And certainly patients with Parkinson's disease have a right to have other primary sleep disorders like sleep apnea or restless leg syndrome that certainly can contribute to this overall phenomenon of fragmented sleep. So the question is, how does one approach that sleep fragmentation, and what are the principles that one can do in order to alleviate the problems? Well, sometimes long-acting levodopa or use of levodopa throughout the night can help that tremor, rigidity, and overnight akinesia. Sometimes avoiding medications that have alerting properties like selaginine and amantadine late in the day, usually after 1 or 2 p.m., can have beneficial effects because these medicines are alerting medications and can cause problems with sleep maintenance. It's very important to minimize fluid intake before bedtime, especially if someone suffers from need to urinate overnight, or if someone is on the water pills, these usually should be taken during the daytime so that they don't cause that need to urinate overnight time. If one needs to get up to do it, bedside commode is a very easy to implement safety measure. And certainly these problems with autonomic system when it comes to urination can be addressed with the medications. Anticholinergic happen to be one of the drug categories that can be used for this problem. The last 2 bullet points on this slide I cannot emphasize enough. It is so critical to recognize depression and other psychiatric comorbidities and also identify other primary sleep disorder, because both psychiatric and other primary sleep disorders can negatively impact sleep, and if they are undiagnosed and untreated, this is a missed opportunity to improve nighttime sleep. So now I'm going to move and tell you a little bit about REM sleep behavior disorder, and this is a very relevant disorder for our Parkinson's disease population. As the name says, it is a REM sleep behavior disorder. It means that happens during that stage of REM sleep that I mentioned at the beginning, and that is a stage of sleep where we usually dream. And in this disorder, for which you see outlined diagnostic criteria on this slide, what happens is that normal individuals, when they enter that REM sleep and fall asleep and start dreaming, become paralyzed. Only diaphragm that support their respiration, or our respiration, is active at the moment, but all other skeletal muscles are paralyzed. In this disorder, in REM sleep behavior disorder, or how we call it RBD, there is a loss of this muscle paralysis during REM sleep. And the second side of that coin is that in addition to the loss of that paralysis, patients usually report and have a very vivid dreams that have negative emotional connotation usually, meaning those are very frightening, very frequently aggressive dreams in which they are being attacked by someone, or they are trying to escape a fire or some other unpleasant circumstance. And now I told you that they are not paralyzed, they can move. And on the basis of that lack of paralysis, is these bad dreams, these patients, while asleep, are starting to act out their dreams. And you can imagine if someone is dreaming that they are in the middle of the fire, they may jump out of the bed, even out of the window, or if they are being attacked or chased by someone, they can try to defend themselves, which can result in choking or hitting and punching their bed partner because they may appreciate bed partner as an aggressor in their dream. In order to diagnose this condition, we invite our patients to the sleep laboratory, and here on this graph, you see a 30-second of sleep recording with many lines on this graph that record various activities, either brainwave activity or respiration. But the point that I wanted to illustrate here is, if you take a look at these two blue arrows, they mark the lines that represent muscle activity of lower extremities of legs. And these lines in normal individuals should be flat because they represent actually muscle activation, muscle activity. And here in this individual with REM sleep behavior disorder, you see these bursts of these vertical lines that represent muscle activation, and these individuals are going through REM sleep. And this evidence of excessive muscle activation on this sleep recording is a signature of this disorder, and this is how we in the sleep laboratory, in conjunction with the history that patients and their bed partners provide to us, this is how we diagnose this REM sleep behavior disorder. How do we approach treatment of this condition? Well, first we need to educate patients and their bed partners about the nature of the disease. Then we need to make sure that appropriate safety measures are in place. Example of these may be that sharp edges of nightstands or bed may need to be padded. All the sharp objects like lamps and things from nightstands really should be removed. Sometimes bed railings should be placed. Occasionally, we ask patients even to put some soft cushions on the floor in a case of a falling out of the bed, which has been reported occurs. When it comes to the treatment choices, we really don't have a lot of research that has been done in this field, but we certainly realize that two classes of drugs, one melatonin and second clonazepam, which belongs to a group of drugs called benzodiazepines, are very effective in treating this disorder. So it is really critical that you discuss with your providers if you have any remote similar symptoms like these that I described. And then if REM sleep behavior disorder is diagnosed, it is likely that you will end up on one of these two medications, and sometimes in challenging cases when one medicine is not enough, one can implement a combination therapy of both clonazepam and melatonin. In my patients with Parkinson's disease, I tend to start with melatonin because I believe it has a better side effect profile. Patients treated with clonazepam may experience a little bit more of sedation that can be problematic upon waking up in the morning or even during the nighttime if one needs to get up and go to urinate. If that sedation properties of clonazepam are really too strong, that can negatively affect affect the state of mind and also balance of the patient and can make them prone to falls. So I usually start with melatonin and then proceed clonazepam if melatonin is not effective. So this disorder, REM sleep behavior disorder, is also very important because it is one of the earliest markers of developing Parkinson's disease and Parkinson's-alike illnesses. And this observation was done many years ago by Dr. Carlos Schenk, who has reported that majority of his patients who have only REM sleep behavior disorder and know any signs of Parkinson's at that time will go on to develop Parkinson's disease many years later. And here I presented to you 3 studies that have shown very strong association between existence of this pure REM sleep behavior disorder and subsequent development of Parkinson's disease and several other Parkinson's-alike illnesses. The association is very strong, and now we know that approximately 40% of patients who have only REM sleep behavior disorder within 1 decade of developing that REM sleep behavior disorder, they will likely end up being diagnosed with Parkinsonism as well. This is a very important to understand concept because now we are able finally to pinpoint to individuals that are at the very important risk of developing Parkinson's disease very early in the process of this neurodegeneration, which opens a great opportunities as new developing therapies become available to maybe slow the progression of the disease very early in its process, and nothing less but targeting a pure sleep disorder. So very exciting research developments in the field that I just wanted to briefly comment on for you all to consider. I'm sure many of you have heard about this, but I think it was my job to stress this again today on this webinar. Now we will move to something that is very known to general public in the United States, and this is a condition called Restless Leg Syndrome. It is a primary sleep disorder which is usually characterized by very unpleasant sensation in lower extremities, usually described as a creepy crawling sensation or water running down the legs or bugs crawling under the skin, etc. And usually these symptoms tend to emerge in the late evening hours, early night, and cause an urge that patient really needs to get up. It's so unpleasant that patients need to get up and walk around. And when they do that, these symptoms really very nicely resolve. But unfortunately, as long as they sit down and resume sedentary position, these unpleasant sensations reemerge. And these are 4 cardinal symptoms what are necessary for the diagnosis of a restless leg syndrome. And this is a busy table. I don't want you to read it, but you will ask me how common is this restless leg syndrome in Parkinson's disease? And the answer is that we really don't know. Studies have reported that up to 80% of patients may have this restless leg syndrome. The challenge is, though, that when we think of diagnosing RLS in Parkinson's disease, the challenge lies in that many symptoms of Parkinson's disease itself may mimic symptoms of RLS. For example, some stiffness or rigidity or akathisia, inner restlessness associated with Parkinson's disease, certainly can mimic and present as unpleasant sensation in legs or arms, and it can be worse in the evening. And sometimes it's really not easy to separate between these 2 conditions. The good news, and here we are at the slide that comments on treatment of RLS, the good news is here that we use the same medications for treatment of Parkinson's disease that we use in RLS. Those are dopaminergic agents, mainly dopamine agonists. Sometimes we use benzodiazepines. Sometimes medications that have been usually initially prescribed to treat seizures may be very effective, and one of these medications, gabapentin. And if all of these options fail, and one is sure that his or her patients suffer from restless leg syndrome, opioids are really a good treatment choice, but obviously due to addictive properties and potential side effects are reserved as the last treatment option for restless leg syndrome patients. Moving along to talk a little bit about sleep disorder breathing or obstructive sleep apnea, another disorder very common in general population, and population is very familiar with it. Couple of points for you to read. Among these sleep apnea disorder, obstructive sleep apneas are most common, and this is what happens in this disease, that there is obstruction of the throat airways by tongue falling back or a very big neck circumference, all these fat tissues, which causes pauses in breathing, which then ultimately cause increase in carbon dioxide in the blood, which eventually wakes up the patient. This is the most common type of sleep apnea, obstructive sleep apnea, but sometimes patients with PD have central sleep apneas that are due to problems with certain areas of the brain that regulate respiration, and this is due to this neurodegeneration associated with Parkinson's disease. An important home take message: when we think about OSA, we think about obese men who have a very big neck circumference. Patients with Parkinson's disease usually are not obese. And we cannot apply that same rule that we suspect obstructive sleep apnea in PD patients who is only obese. So this is very important, because if you suspect that you may have a sleep apnea, you may not need to be obese, to be considered as a good candidate that needs to be looked at from the perspective of sleep disorder breathing. And here, this is this illustration, one anatomical chart that shows that this big, large tongue muscle has completely blocked our airway of this individual, which is laying on the back, which is really the most common position that makes people prone to this problem. These are therapies that are available, and the mainstream of therapy is really positive airway pressure therapy, which is a CPAP, where there is a machine that pushes air through your nostrils or your mouth, or both through your nostrils and through your mouth, and that pressurized air opens this blocked airway and maintaining it open throughout the nighttime, so there are no dose interrupted consequences of snoring and repetitive awakenings throughout the nighttime. Now we're going to move fast, because I want to make sure that I have enough time for your questions. We're going to talk about excessive daytime sleepiness. This is a phenomenon brought by Dr. Stephen Frucht from Columbia University in New York City to us, when he reported that 8 of his patients with Parkinson's disease treated with dopamine agonists have had this sudden onset sleep while driving, which resulted in many in motor vehicle accidents. So very important clinical observations for our field. And excessive daytime sleepiness is now a very well recognized problem in Parkinson's disease community. And here in this study, about 15% of patients with Parkinson's disease suffered from it, relative to 1% of healthy controls, individuals without diseases. We now know that this 15% number is much bigger. Why is this important? One of the consequences are issues with the driving. And in this study of over 5,000 people who had a driving license in Germany, we understand that approximately 10% of them experienced sudden onset sleep at the wheel. And quarter of them and half of them, over half of them, had absolutely no warning signs of sleepiness. So when I discuss sleepiness with my patients, and I do it pretty much every clinical visit, I always ask them about it. And you bet that the responses is going to be sometimes, "Oh, doc, don't worry about it. I just have my cup of coffee next to me. I blast the music and open the window so that wind can hit my face." And I said, "Well, that's all nice, but it's not going to work. And, we need to find other ways." Because as you see from this large study, many patients who have excessive daytime sleepiness can fall asleep at the wheel without any preceding warning for incoming sleep. And this is a huge safety issue for our patients and their other individuals on the road. Causes are very numerous. Obviously, complex medication regimens, other sleep disorders that are undiagnosed, and certainly this neurodegeneration of Parkinson's disease that affects these sleep-wake regulatory centers. It is very important to get a good history from a patient and from the spouse and caregiver, because patients may not realize that they are falling asleep. It's critical that we take a look at the medication regimen, because some of the medications may need to be adjusted based on this excessive daytime sleepiness. Patients must be screened for other primary sleep disorder or disorders, and then there is a series of tests here that I abbreviated for you that can be done to either study sleepiness via various questionnaires and scales, or this MSLT, multiple sleep latency test, which is in-laboratory testing where we objectively can study the degree of sleepiness that patients have. Treatment obviously starts with the sleep hygiene. It is important to address coexistent sleep disorders. It is critical that medication regimens are reviewed and adjusted as needed. And really, one of the mainstreams used to treat excessive daytime sleepiness nowadays in this medication called modafinil. Sometimes we have a hard time getting approval for it if there is no coexisting sleep apnea. In that case, it's much easier to get approval. Stimulants like Ritalin and other medications in that class have been very popular in the past, have fallen out of popularity due to potential side effects, negative effects on cardiovascular system. Sometimes deep brain stimulation may be associated with improvements not only of daytime sleep, but also of overnight sleep quality as well. And now, at the end of this presentation that I have for you, I wanted to point out to you to some exciting novel developments of so-called circadian system, which is a system that controls any of our bodily functions, and it is organized by this internal clock, central clock in the brain, which is called suprachiasmatic nucleus. And what this clock does, he receives the feedback from outside world, from sunlight or for any bright light that hit retina, for example, and then that information travels to this clock, and then the central clock called suprachiasmatic nucleus is in charge of synchronizing other brain clocks, and clocks not only in the brain, but in the other organ systems. Every cell in our body has its own clock, and every organ in our body is synchronized to work nicely with each other. So it is this suprachiasmatic nucleus which is critical for the regulation of sleep-wake, but also cardiovascular health, GI motility, our mentation, etc. So why is this so exciting? It is exciting because I told you that circadian system receives input from outside world, and the most important input then synchronizes that internal clock is bright light. And therefore, we have a great opportunity to use that circadian system as a therapeutic target, and we have illustrated this by one clinical trial that we have recently published, where we applied light therapy twice a day to our patients with Parkinson's disease who suffer from excessive daytime sleepiness. And here you see that light box that emitted that light therapy twice a day. And after these patients have been exposed to this bright light therapy twice a day for 2 weeks, they have reported better sleep consolidation and quality and improvement alertness during the daytime. So this is one relatively easy non-pharmacological therapy. You will be seeing more studies in this area coming to the market, and I think we have a great opportunity now to hit this internal clock with these non-invasive, non-pharmacological therapies that can hopefully synchronize our sleep-wake cycles, but maybe even our other bodily function to improve the symptoms of the disease, and who knows, maybe affect Parkinson's disease in some other ways. If this is of interest to you, I'm going to use this opportunity to tell you that we have another clinical trial that is now ongoing, light therapy trial for patients with poor nighttime sleep in Parkinson's disease. So you can reach out to us or look us up at Fox Trial Finder or clinicaltrials.gov. So I think you know that I'm going to close this webinar again by thanking you, or close my presentation, by thanking you for joining us today. And I'm going to urge you to think about your sleep and to tell your physicians about your sleep, because one thing is certain. Sleep disorders in Parkinson's disease patients are underreported by patients and their caregivers. At the same time, they are underdiagnosed by health professionals. It's also known that patients who sleep better feel better, and that Parkinson's is less benign, is more benign the following day after a good night of sleep, phenomenon known as a sleep benefit. So I really urge you to think about your sleep, but also to talk to us about potential research collaborations, because this is the only way how we can advance this field better and help our patients and their families, which is really our main mission and task. So I would like to close my presentation at this point, and believe we'll have a chance to interact through Q&A session for the next 20 or so minutes.
That's right. Thank you very much, Dr. Videnovic. That was fantastic. I really enjoyed the talk. And we've had a lot of questions come in we've got over 400 people who are on the line live listening to you speak. So if you don't mind, let's just go on and start right at it. You mentioned melatonin and as one way with which to do it. And so we've got two questions that have come in. One is from Illinois, a nurse, and she's asking about the dosage that you recommend. And then another person from Texas is asking, is it okay to take melatonin every night? What are your thoughts?
Sure. So I'll be very brief. Melatonin has two uses for treatment sleep problems in Parkinson's disease. One is to improve insomnia and sleep continuation. Second is to treat REM sleep behavior disorder. I usually tend to start with the 3 milligrams at the bedtime, increase to 6 milligrams, and subsequently to 9 milligrams if needed in 7 to 14 days intervals. When I need to go higher than 10 milligrams a day or night, I'm cautious, because although benign, this medicine can cause some confusion as the dose is higher than 12 milligrams. And certainly, there is no harm of taking medications on a nightly, this type of medication on a nightly basis. So especially if someone has REM sleep behavior disorder, we recommend this to be a nightly continuous therapy.
Okay, that's really helpful. So you also mentioned, speaking again of these kind of alternative approaches, for the light box therapy that you just mentioned, question from Wisconsin. Do you need to use it twice a day? Is it once a day? Is this something that's still kind of experimental? Where
Yes, this is a wonderful question. One needs to look at the light therapy box similar like a pill. That light therapy box needs to have its dose, its duration, its frequency, and at the moment we really do not know fully what is the best time of the day, what is the best duration, what type of light one should give it. So at the moment, at least based on my experience, I would recommend that it's used twice a day. In our study, we use it for an hour at a time, which is really long. I do believe that if one uses a bright light therapy, that 30 minutes may be enough. But I would also like to urge you not to start light therapy without speaking to your physician about it, because it does have same rules that would apply to taking a pill must apply to taking a light. If one takes a light exposure or very early in the morning or late at night, it can be actually harmful for sleep-wake cycle. So consider light, but talk to your physicians, talk to us, and just to make sure that this therapy is administered appropriately.
Yeah, thank you, Alex. I appreciate that. it's a really good point. Just so at the very least, your partner in treatment, your clinician, is aware of what you're doing, just so that they can keep that in mind as they deal with other issues that are going on. Now, I've got a question for you. This is a question from Finland regarding exercise. Now, how do you view exercise as a way with which to help maintain sleep hygiene? Is it something that people should do before they go to bed in the morning? How does that regulate someone being able to get that good night's sleep? And then I'm going to follow up with a couple other questions we have regarding how do you deal with sleep fragmentation?
Sure. So exercise undoubtedly has positive effects on sleep itself. It will have positive effects on motor symptoms of the disease, on depression and anxiety as well, and that's going to feed in a good night of sleep as well. One needs to do exercise that he or she enjoys, because that's going to be the recipe for success. But too much exercise, for example, before bedtime, may not be soothing for some patients. I think when it comes to exercise, the state of the art, we need to experiment a little bit and see when is that we benefit or our sleep benefits from exercise. Because pushing exercise very late at night can make us actually over alert and making more challenging for us to sleep. So I think that if one picks up a mid-afternoon or a very early evening as an exercise regimen, I think this would be really certainly the best time, at least based on my understanding of the literature, when it comes to sleep benefits from exercise. And another question was about the sleep fragmentation, right? But that was not necessarily linked to exercise, correct?
No, not entirely linked. I was just going to, because exercise we were talking about is you can leave people to be awake and have a hard time falling asleep, and so the flip side to that coin is, as you brought up, the sleep fragmentation and people waking up. When that happens to a person, and it may happen for various reasons, some of them very serious ones as you bring up, but others are maybe more minor, what would you recommend for someone? Should they lay in bed and try to tough it out?
Oh, I see.
And walk around?
Good question.
What's your approach?
Right. Well, really, the number one approach should be we need to think about what triggers that fragmentation, right? Is it urination problem? Is it emergence of tremor? Is it that patients wake up and they are so worked up what's going to happen at work tomorrow and they are anxious and think about their future? Because attacking these causes is going to be the most effective way to deal with this sleep fragmentation. If one suffers from it and it's really hard and challenging to treat it, etc., after you wake up in the middle of the night, I would really suggest that you get out of the bed, that you walk a little bit around. I'm not sure that it's a lot of patients do, but I'm not sure it's smart to turn the lights on and then start reading, because that's going to suppress melatonin, which should be really at the highest peak at that time overnight. So I would just try to do some relatively quiet sedentary activity in a very dim lighting, and then try to go back to sleep. But I agree that laying in bed for hours is just really going to be more aggravating situation. If you wake up in the morning and it's like an hour earlier than you would like to get up, don't try to sleep. Just start with your day, and then the following night, hopefully, you will accumulate that sleep depth, and you're going to be able to fall asleep easier.
Thank you, Alex. So, Dr. Videnovic, you raise an interesting issue, and that's turning on the light in the middle of the night. And for people who have to urinate in the middle of the night, is there a way? I mean, is there kind of something you recommend to your patients to have, like, low light night lights in their bathrooms or on the path, so that they don't have to turn the light on, and then really kind of reset this circadian cycle that they're working so hard to try to get trained to the normal time?
I think this is a very important point, and I think that I always recommend night lights, especially in the bathroom, which is really a very problematic location for me when I think, as a clinician, think about home at night. The bathrooms are usually set up for potential disasters because of the falls and hard surfaces, etc. So I really do recommend the night lights. And usually those night lights are not going to disturb cycle. You really need substantial light exposure, overhead lighting, etc., that can suppress that melatonin. But if you have a well-positioned night lights in a bathroom or even in a bedroom at certain locations that can assure your safety and not cause a lot of interruptions in your sleep-wake cycling.
Okay, perfect. So I want to follow up on, and we've got some questions about this regarding, you brought this issue up of restless leg. And so when a question arises, does restless leg lead to RBD? How are they related at all? I mean, in the long scheme, I mean, clearly they're different issues that someone may deal with. What do you?
Yes, yeah. So these are very different diseases, and it's important to understand that they are not related to each other. One will not lead to each other. The difference in relation to Parkinson's disease is that RBD has a clear association and poses a risk. It's already maybe Parkinson's in the development. Patients who have a restless leg syndrome have no risk of developing Parkinson's disease more than individuals who do not have it down the road. So two very different sleep disorders as on its own, and also when it comes to its relationship with Parkinson's disease.
Okay. Now, we've touched a little bit on non-traditional approaches. We talked about melatonin and other things with which to help with sleep. And you also mentioned some medications with which to treat RBD. Now, one listener from North Carolina is asking about sleep medications like Ambien. Is that something that you recommend at all for people to take? Is it something used for short periods? Is it, what are your thoughts on using sleep medications like that?
Important question for entire sleep medicine, not only sleep in Parkinson's disease. Home take message, at least from my clinical practice, is that I really try to stay awake from Ambien and similar classes of drugs. I think that we have a much more benign profile of other classes of drugs that we can use to improve sleep compared to Ambien and similar drugs. I think that small doses of antidepressants can do miracles for someone's sleep and would certainly prescribe these much more comfortably than prescribing Ambien. Having said that, do I have a patients who will take Ambien here and there? Sure, I do have them. It is very important to counsel them that patients with Ambien can have some really sometimes problematic overnight behaviors. They can develop these nighttime eating episodes where they need to get out and start eating, and they are all fully asleep. So this nighttime eating disorder, they can have a lot of grogginess or sleepiness during the daytime, kind of become a little bit addicted to this type of drug and not be able to initiate sleep without it. So as a last resort, I certainly would try to help my patients by prescribing these drugs, but this is a relatively low on the list of treatment choices that I will try first before I proceed to Ambien and similar drugs.
Okay, that's good to know, especially thinking about this population. So I've got a questioner from Canada who maybe you think about the occasional use of something like Ambien and then long-term use of melatonin, and this person is really asking, I think, an interesting question, because in this day and age, a lot of people are traveling around the world, and many people with Parkinson's still have jobs. So how do you deal with jet lag with Parkinson's? Is it worse in people with PD than the general population? Is this something that, we talk about melatonin, is it something people would take melatonin ahead of time, I've heard people use, or is it just simply that someone would just maybe take an Ambien to help power through that brief episode where they need to be able to get to sleep when they need to? What do you advise your patients who are in that situation where they have to worry about jet lag?
Sure. Well, jet lag is a very interesting phenomenon. The first part of the question was an answer is that we really do not know how is jet lag affecting patients with Parkinson's disease as opposed to those that don't have Parkinson's disease. Now, the treatment of jet lag, although it sounds relatively simple, it has a really science behind it. So light exposure to certain travel destinations is very, very important and at the time of arrival. So if we are talking about the transatlantic or trans-Pacific flights, exposing yourself to light at the appropriate time of the day is really very critical. For example, if arriving to Europe from United States in the very early morning hours, where it's very bright over there, we should really try to keep the light exposure to a minimum until we hit afternoon in Europe. And we should try to do that couple days in a row. So not much light in the morning, a lot of light in the evening. If you go to Asia, the pattern should be completely different. Similar things apply if you travel from East Coast to West Coast, right? East Coast from West Coast, people should limit exposure of light in the morning. But not to dwell too much on it, light exposure is important. Melatonin can be very useful. So what I would suggest that patients, when they travel, that they try to take 3 to 6 milligrams of melatonin about an hour to hour and a half before desired bedtime. And they try to do that for a couple days at the new destination, and that should be able to smooth their rhythms. There are many other more involved ways how to deal with the jet lag, but we really don't need to go into those details at the moment. It's very complex, and a really small number of individuals decide to do those approaches anyway.
Okay, well, that's good to know. So just changing gears a little bit, we talk about aging population. Someone from Illinois is just asking about the fact that since they've had Parkinson's disease and they've gotten older, they don't sleep as much. And so is that something to be concerned about? Is there an issue where getting too little amount of sleep is detrimental to health, even though they seem to be functioning? They're not tired during the day. What are your thoughts about that?
So in general, regardless of the age, sleep needs varies among individuals in a general population. With aging, invariably, there may be some reduction in the total sleep time, but not really much as one would expect. So I think that as long as one functions well, some reduction in the total sleep time should not be considered as necessarily negative. The issue is when reductions are really large and when one doesn't sleep enough. And the statement that should go with this sleeping enough is what is enough, right? And we really don't understand that how much sleep is enough sleep. But some large epidemiological studies hint that anywhere between 6 to 8 hours of sleep should be sufficient. So I think that our patients should strive at least for 6 hours of sleep at night. And interestingly, we know that more than 8 or 9 is not good either. So it's important to find a nice balance, but also not to obsess too much about the number of hours, as long as they are reasonable, just because we sleep less than we did 5 or 10 years ago.
Okay, that's good to know. Now, we're nearing the top of the hour, and I just wanted to pause briefly in our Q&A because we have a couple more questions, and hopefully, Dr. Videnovic, you can stick around just a bit longer. But I want to let everyone know there should be an online survey which should be appearing on the screen, and that your feedback is really important to us to help design and ensure these webinars are reflecting of what you need in the community. So please take the time to fill it out, and we use that information as we design our webinars. And of course, again, I want to call out the AbbVie, Acadia Pharmaceuticals, and Lundbeck for the sponsorship that they've done through a non-restricted educational grant to allow us to put on this expert briefing today. So I've got a couple interesting questions coming from West Coast and East Coast as well, Colorado and Maryland. And they're talking about being noisy sleepers. Is there an issue about being a noisy sleeper and Parkinson's disease? And these people are suggesting that they're not just snoring; they're groaning, they're laughing. They've got these, I guess, making different noises like that, and they're just trying to understand is that how does that relate to sleep, Parkinson's, and maybe even RBD?
Yeah, so I think, if there are laughs and some verbalizations that are new, one really needs to consider, is there maybe some REM sleep behavior disorder? And I just want to point out something that I probably, and actually I didn't stress when I talk about REM behavior disorder. Not all REM behavior disorder is violent. Right? There may be a minor leg movements or a minor vocalizations overnight that really are happening on the basis of a REM sleep behavior disorder. So one doesn't need to remember dreams at all and may have just a minor movements of arm and leg and still have REM sleep behavior disorder, which is good. So not every REM sleep behavior disorder is violent. So certainly some of these noises and movements may be related to REM sleep behavior disorder. Sometimes patients will periodically kick their legs when they sleep, and this phenomenon is known as a periodic limb movement of sleep, which is independent sleep disorder and certainly may be related to restless leg syndrome or not. But these periodic leg kicks may be completely independent sleep problems that has been undiagnosed for a long period of time. It's also important to find out that sometimes patients will have these episodes of falling out of bed, and they will not remember anything except falling out of bed, and bruising their forehead. And at that time, one needs to strongly consider REM sleep behavior disorder as an underlying cause. And I have had many patients that have had many fallouts of bed for unknown reason in the middle of the night and while being asleep. So sometimes in order to ascertain which problems are really which, it's important to come to the sleep laboratory where we can video monitor you throughout the nighttime and know exactly which type of behaviors happen at which stage of sleep, and therefore make a diagnosis of this phenomena much more accurate.
Okay. Now, when you talk about sleep labs and polysomnography, that assessment of someone's sleep, how does one go about that process? Would one talk to your Parkinson's doctor? Would you talk to your general practitioner? And are these labs common? I mean, do you have to go to a real specialty center, or can they be found throughout many places in America?
These labs are very numerous. They are available almost pretty much in every city, every town. And it's important that one has a clear discussion, either hopefully with a Parkinson specialist or neurologist, but also maybe with a sleep physician if you have one, or even with your primary care physician, because not each sleep disorder and sleep problem will require sleep laboratory examination. And it's important not to overutilize the system with the rising costs of healthcare. And for some sleep disorders, for example, for insomnia, someone just doesn't sleep well, but there is absolutely no suspicion for a REM behavior disorder or for obstructive sleep apnea or anything similar like that. Sleep study is actually not indicated. But if there is a strong suspicion for any of these disorders, then I would suggest that you connect with your physician, who will then write an order for a sleep study in the sleep laboratory that then goes to insurance approval. And after all that is cleared, you get a call from the sleep lab, and you can, at your convenience, go ahead and schedule a night of sleep in the sleep laboratory setting.
Okay. Now, I've got, just a couple more questions, just keeping cognizant of your time, Dr. Videnovic. Thank you very much again for speaking to us today. A couple people have asked from Missouri, New Jersey, and Ohio, asking about how their Parkinson's meds can affect their sleep. You've mentioned a couple that may have trouble, but what about the traditional ones like Sinemet? Are you aware of any issues regarding Sinemet and problems with sleeping, or even people who may be on continuous supply? We've got a person from Ohio asking about Duopa. Are there any issues with that impacting one's sleep?
That's a very important question, so I'd like to thank you for that question. And Sinemet itself is much more benign when it comes to potential problems with sleep compared with the dopamine agonists such as pramipexole, ropinirole, or otigotin. Sometimes patients may have paradoxical reaction, and if they take Sinemet at the bedtime, they may become more alert, etc. And that is all due to their internal makeup, if you wish, and which dopamine receptors get stimulated and at what amount, et cetera, for which we don't have time to go into details now. So home take message is, if one has a lot of motor symptoms overnight and needs to start to take Sinemet at night, I have no problems with that. With the caution, then one needs to follow up in a few weeks of initiating this therapy. How is this therapy tolerated? As the disease progresses, the challenges with Sinemet and nighttime sleep may be due to negative effects on cognitive profile and mentation. And nocturnal hallucinations can emerge with increased dopaminergic load and increased Sinemet, especially in patients who have cognitive problems are in more advanced disease stage. So in this patient population, it is very important to carefully monitor overnight intake of levodopa, and sometimes that really is not an option because of these negative neuropsychiatric complications that can happen at that disease stage.
Okay. Thank you very much, Dr. Videnovic. I think this has been a fantastic session today. We have lots of great questions. I want to thank you again for your time. And I also want to let people know that we're going to have an archive of our event today that's going to be available on Tuesday, June 20th. And you can go to www.pdf.org for that archive of the presentation. Our next series for the ninth series will start again in the fall, so please look forward to that. We already have many of those talks set up, and the first one's going to be on nutrition and weight management. It's going to be Tuesday, September 12th, 2017, so mark your calendars, 1 p.m. Eastern Time, and Dr. John Duda from University of Pennsylvania and the VA system there will be presenting about nutrition and weight management. I'd like to close by thanking again our generous sponsors from AbbVie, Acadia, and Lundbeck for their support, and thank you for listening. Have a good day.